we are going to cover the most common gut issue in the world right now. It is most likely statistically IBS, and what is underneath that is most likely small intestinal bacterial overgrowth in the highest probability of cases. How to understand it and screen for it, and by the end, give you the foundational theory and knowledge you need to know before you go to the next step, which is how do we address it in ourselves? How do we educate our clients on improving it in themselves? This is going to be a theory heavy, so make sure you take lots of notes. 1/3 of the people who test positive for SIBO, 1/3 of the people who have, I sparred yesterday, 1/3 of the people who have IBS test positive for SIBO, but estimates vary quite a bit. And that's something to know. And that when we look at this constellation of symptoms and this diagnostic framework of IBS, when we measure those people, it's a bit of a range, somewhere between 13 to upwards of 50% of those people seem to be confirmed for SIBO with certain testing parameters like a breath test. But that is also has its limitations as well. If you guys can't recognize how to support the most common gut issue, such as SIBO, then you're going to miss this big piece and your clients will end up suffering if they don't have external help. Often it's quite financially challenging for a lot of our clients to get multiple professionals in their corner, even though we recommend it. And inevitably, if you guys can't support your clients in the way that they need, then it does in some ways damage your trust, your ability for people to refer you, and your reputation. Some of my best testimonials on health, if you want to view them, are actually gut related. So you can see the effects of that up there. And so this masterclass aims to close that gap for you guys, so you can get better results and you can have a more empowered skill set. So the plan is to be able to recognize SIBO, understand its mechanisms, what drives it, know who's at risk, so certain risk factors, know how to map the symptoms to the different types of SIBO, understand the overlap, understand testing, and the different correlated hormonal conditions that can come with it or that can be associated with it. Now, I figured I should show you a little bit of social proof, like why should you believe me type thing. Even though you guys have all great trust with me, I think it's important to show a degree of social proof and also show you how you can document your testimonials. This is Mary, a great young coach, and just a simple before and after. It's very easy to kind of like fake these before and afters. However, this is not faked. And Mary was working with me for the good part of maybe a year and a half. And we saw stress being a major driver for her fluid retention and her bloating and gut issues. This is Bree. Now, Bree, to my estimation, I believe had SIBO. She did do a breath test and it was confirmed with the breath test. And she was dealing with a whole host of like other correlated symptoms as well, particularly psychologically, a lot of anxiety, low stress tolerance, depression, skin issues, and she also lost some weight as well. Here's some testimonials that you can watch. I flew Bree down because she had such amazing results. These are just some more like testimonials and things that you guys can see for proof and also some inspiration of what you can do as well. Now, one of my first posts on Instagram was actually me working through my gut issues. This was, you can see Yersinia. It's a dysbiotic bacteria. And then we have some commensal bacteria in the middle, like Klebsiella, Staphylococcus. These can go either way, beneficial and dysbiotic. I did a stool test with an integrative doctor. I did some posts about it to document my own health issues that I was going through. And my point was, it's one thing to look good on the outside, but if you don't feel good, or if you're not healthy on the inside, then you are living in ways, you should hold yourself to a higher standard to work on that. More of me documenting what I did, kind of the healing phase that I went through. I probably spent like $1,000+ on supplements to address my issues. And now I want to show you some of the symptoms that you guys should watch out for first. Signs and symptoms. Now, I've underlined what, in my experience, if it's underlined, it means observationally, as a coach and with colleagues of mine, I see it to be much more related. This is what you want to watch out for. Long-term distension. Distension is more than like, I feel full. It's you press against your belly and it feels a little bit like a balloon. Allergies. I see that as common. Inflammation isn't really a symptom. It's more of a mechanism, but lethargy. egg-like flatulence. That can be from a number of reasons because of sulfur producing compounds, or the gas sulfur being produced that's causing that scent, which can also be caused by foods like cruciferous vegetables, eggs, some meats, high sulfur foods. Inability to tolerate garlic, onion, all those cruciferous vegetables, that's a giveaway. And those are our FODMAPs. I couldn't eat. Guys, when I was going through my phase, man, I had to find I couldn't go to any restaurants. I was so strict. It was crazy because I think I was developing an eating disorder from this shit. And from I'm not even joking about that, from my coach at the time, because it was so strict. I found a FODMAP cafe in Melbourne. That's how common this stuff is in Melbourne. I was determined. Brain fog, constipation, loose stools, correlation between endo and PCOS. These are the symptoms you guys want to look out for, particularly underlined. Cool? Any comments?
This is very relatable.
It's very relatable. Okay. All right. This is fun. Great. You're in the right place. If it's fun, I love that, Sarah. If it's fun, it's such a good sign that you're in your zone. Because if this can be fun for you guys and you like learning it, you can get paid to have fun. Oh my God. That's insane. Very happy about that. Now, great. Ask lots of questions, make lots of comments. Signs and symptoms of SIBO. In more severe cases, and I'll explain exactly what SIBO is in a second, but I want to show you what to look out for first. Diarrhea, it's like a fatty type of diarrhea where the stool floats to the top and it has a high composition of fat in it when it floats, because fat is more buoyant. You'll see that less commonly. Excuse me. Nutrideficiencies can be implicated here, which is where we can get the constellation of outcomes like nutrideficiencies, B12, minerals. Now, on the right, this is from a study. On the right, you're going to see the symptoms that I told you guys about. But on the left is the more clinically significant symptoms. When we say that, we mean IBS has a higher severity, something that you would look to refer more likely to a gastroenterologist or a naturopath or a dietitian, particularly if you wanted some extra support. Who does this affect? Can you guys see this photo? Look at all of us. We all, no Trinity on the top, we got SIBO on the top. Well, yeah, remember? I got some good ones. It's distorted our faces a bit, but it's realistic enough. High-risk populations. Just to reiterate, what you want to look out for: high antibiotic use, high antacid use, abdominal surgeries in particular, previous infections, autoimmune diseases, which often, it's kind of like chicken and egg with this stuff. Of sometimes the autoimmune disease is a trigger from an environmental issue, whether we're talking mycotoxins, whether we're talking mold, whether we're talking high stress events, like a concurrent combination of different environmental triggers. Eating disorders. This is something I've seen in my experience over the years, is that have a guess why you think eating disorders can contribute to gut issues, and put it in the chat. I also see our bodybuilders, our athletes, whether it's endurance athletes who are doing repeated long bouts of multi-hour events, I tend to see issues with them. And then the bodybuilders who are in surpluses for long periods of time. Eating disorders, less variation with food and more stress. It contributes, but there's something else there. Think about the symptoms of an eating disordered behavior. Think about someone with an eating disorder that they may be purging, which means self-inducing vomiting. They may be taking over-the-counter drugs to help them go to the bathroom, to purge in another different way. It's technically not called purging. But particularly if they are purging, particularly if they are overeating and they're going through these very big binge cycles of overconsumption and then fasting and then hard training, it's a combination of different drivers that can contribute to hypochlorhydria, at least mechanistically. It's very plausible, and I do observe it, which can then obviously affect the absorption of food. And that's just a few of the drivers. We can go much deeper into eating disorder behaviors, but that's something I just want you guys to be aware of and look out for. Now, what is SIBO? We've covered the symptoms. what to look out for. But technically, what is it? So this is defined from research. So you want to be aware of this language. The presence of excess colonic bacteria. What does colonic mean? What area of the gut are we referring to? Yes, the colon, but what bigger area? Yes, thank you. Sarah, I'd like to hear more in the chat, as in like alluding to what you mean. Excess colonic bacteria. So stuff that should be in the large intestine, this is very layman's term, stuff that should be in the large intestine has moved and translocated up to the small intestine. This is just super sciencey. Don't have to remember this. It's just a definition of like the quantity of bacteria that should be in small versus large. Gastric acid secretion and intestinal motility limit the overgrowth of bacteria in the small intestine. What does this mean? The presence of gut secretions or stomach secretions and acidic gut is good. It's antimicrobial. Intestinal motility. When we have good motility, when things are moving in the way they should be, when you don't feel that food is like being like stuck in you, is going to be the felt sense of feeling. It's also the symptom is gut motility, or rather the mechanism is gut motility. If things are moving as they should be, then that's good. That limits the overgrowth of bacteria, but often that's not the case. So when these mechanisms are limited for a number of reasons, like the risk factors that we said before or others, we can have an environment that's more likely for SIBO or other bacteria or dysbiotic bacteria to proliferate, to grow, to manifest. What we're seeing is this I don't like to be too reductionist, which means I don't like to like break things down so simply because things are much more complex than this, but it's worth making things simple so you can explain it to your people. This is argued a bit, but we think bacterial migration, then food is fermenting. What does that mean? Food is more likely to ferment in the small intestine when there is that bacterial migration up. Then it triggers gas production, methane, sulfur, hydrogen. Then you like shit in your pants, all gassy. Man, you stink. Ugh. What's wrong with you? How many eggs you eat? Ugh. Brother, I got SIBO. Sister, just SIBO. And you get the gas production. Oh, Sarah, jeez, please. That's quite a combination you had. I wanted you to speak soon. I just want to finish this thing. Now, nerd stuff, I think it's cool. At the top here, we have can I zoom in? No, sorry, Matan. We have a normal distribution of intestinal bacteria, okay? So we have the duodenum and the jejunum, one of the best words of all time. Isn't that right? This is early in the small intestine, remember? Just after the stomach. Now, what do the colors mean? When it goes green, think more bacteria concentration, okay? So the bacteria concentration in the top here in a healthy gut is more towards the colon, very dense in the colon, in the large intestine. Cool. So that's positive, healthy. Now look at the bottom. The bottom shows a lot of green, earlier up in the intestine, more towards the jejunum and in the small intestine area. And given that high concentration of bacteria, you're more likely to get fermentation and gas production, which is shown in this bottom black horizontal line in the green. Be glitching? I might give it a second. Bacterial migration, another little summary, another little image that you can kind of conceptualize. Remember, the migrating motor complex seems to be a central mechanism in this process. It's these cyclical contractions that sweep the bacteria. You got a street sweeper in your gut, MMC. When we snack a lot, we reduce that. When we have slow gut motility, so things are slow. If you see a client and like, well, man, it takes forever. Food just feels like it sits in my stomach, is the felt sense that you can hear. Well, you can most likely extrapolate that to perhaps the MMC is not going to be functioning as effectively. We can never know for sure, but we can only suspect things. Chronic stress, frequent snacking, low stomach acid all impair this function, which probably means that there's going to be a high likelihood of fermentation and dysbiosis risk in general. Ooh, I'm zoomed in so much. This is a bit of a summary. Bacterial migration, fermentation, and gas production. Producing gas, hydrogen, methane, hydrogen sulfide that cause pain, somaticide, gasiness, bloating, diarrhea, or constipation, depending on the dominant gas type. Systemic, which means broad, general effects. We can see some mast cell degranulation when there is intestinal permeability. We're not technically talking about leaky gut right now, but they can come together. And so usually I'll see SIBO, dysbiosis, picture with a bit of leaky gut, which then potentially can contribute to other cognitive or neurological symptoms, which can make it a bit challenging because there's a few things going on. Here's another image that you can look at that helps explain what we were looking at before. So again, you can see the concentration of organisms being earlier on, more fermentation. Now you can tell this is not listed in the presentation, but gut transit time. How long approximately do you think it takes for food from your mouth to enter your small intestine? Give me the approximate. How many minutes do you think on average it takes? 2 hours is one guess. 2 to 3 hours. Thank you for guessing. 11 minutes per 10 calories or 100 calories. Whoa. That's very specific. That almost feels like you've cited research. Is that?
I have heard, and I have just pulled that out of my encyclopedia inside of my brain. I cannot recall where it's from, but 11 minutes is when the first lot of calories starts transporting into the small intestine, I think, from the memory. Sometimes it's wrong, but it's quick.
Okay. I'd be very curious if there is research on that. I have not seen that, so I can't confirm or deny, but it's quite specific. Okay, a few of you have guessed. Why this is important is because when you ask your client about their symptoms or yourself, and you can think, when did I eat food? How long did it take to digest? What is it hitting? Stomach, small intestine, or large intestine? Hard for you to exactly know, but you can get a general ballpark. So generally speaking, if you can see me, generally speaking, 30 to 60 minutes from mouth to, well, technically it's like minutes from mouth to stomach, but that stomach digestion process can sit somewhere between 30 to 60 before it's released into the duodenum, into the small intestine. So small intestine, it can take from mouth to small intestine, it can take 60 to 120 minutes, depending-ish on the volume and the food and whether you're fasted or not. If you're fasted and it's overnight, then motility is faster. If you've had a meal before, it's going to be slower. Why this is important? Because when you think about yourself and feel about yourself and you're like, how long did it take me to feel this symptom? 30 minutes, 10 minutes. Okay, that food was probably still in your stomach. Good to know. That's helpful for you, like, okay, small intestine region. Could that be SIBO? Could that be like something to do with my small intestine? Could there be some dysbiosis there? Very nice, Zoe. I haven't looked at the research, but could you just do some quick math for me on a 500 calorie meal and a 1,000 calorie meal and a 1,500 calorie meal and do the math on that for me? Let's keep moving. This little squiggly guy, it does not mean equals. It does not mean SIBO equals IBS. Do not say that shit. It's not right. Many IBS diagnoses, it's going to be easiest for you to understand IBS. Like clients will speak to you in IBS terms, doctors will speak to you in IBS terms. They typically won't understand SIBO. Many times, commonly, it is SIBO. Not always, but many times. So understanding this changes how you communicate, your approach, your education. IBS is not typically specific to explaining a reason why we are here. Like, what is the driver? What is the underlying mechanism that's causing this? But SIBO, Mr. SIBO, which maybe Leon, your girlfriend, has, potentially, it starts to explain the process and mechanism, which then helps us formulate an accurate plan.
So, do you reckon like people use IBS more like an umbrella term?
It seems to be that way.
Like even from clients and stuff. Now that I'm seeing and understanding this, I feel like, yeah, people just go like randomly throwing out, yeah, I got IBS, but they have to look deeper into it and understand what's actually going on.
Yeah, it seems to be that way. I would speak in the language they understand and then look to help educate.
Thank you.
Yeah, I think your feeling is accurate. while we're talking, Sarah, I think it's worth you sharing, if you don't mind. You said things are kind of clicking. Like, do you mind sharing your experience of what you're saying in the comments to help give everybody some perspective?
Yeah, so I'm talking about my like when I had really chronic eczema, like when I went through my big health crisis a few years ago that led me here. I just feel like the more that time goes on, the more and more I'm like picking up all these little pieces of things that I'm learning and seeing how they all contributed to that downfall. Because I think a lot of people like to find one thing that is like the reason they got sick, but a lot of the times with those sort of things, or like autoimmune diseases or eczema like I had, and gut issues, it's it's multiple things that fill up your bucket, like your
Yeah.
allostatic, or is it allotistic?
Yeah.
I don't know how to say it.
It's not
Yeah, I thought I just sounded like autistic. Allostatic load, it all builds up, and like I keep learning more and more about that. Like I think about all of the different things that I was doing at that time in my life, and all of the things I was feeling, and just all of the different parts of my life. And even though from the outside I looked like a healthy person, like I was really fit, like my body looked good, um like leading up to it I had pretty good skin, and like I was working out all the time. I'd train for like 2 hours a day, and then I'd walk for like another 2 hours a day. Like my whole life was just training and walking and gym and like gym meals and all that sort of stuff. But underneath, like I was just killing myself. I think about like I was overtraining. I thought it was better to train more, but little did I know that that was slowly like degrading my gut health. And like I said, on top of that, then I had stress. Like I was in a relationship that like I felt stuck in, so I had that on top of that feeling, like in my chest, like I felt trapped. And then financial stress and all that sort of stuff. It just, all those little things, they just build up and build up and build up, and then, oh, like how did I get so sick? Like why am I like at rock bottom right now? And then you look back and see it all.
So thank you for sharing that. I hope you guys were listening, because what Sarah is describing is this like constellation of experiences and symptoms and drivers that contributed to her poor health. It wasn't just like one thing, it was a bunch of things. And so as a coach, you should probably coach. It's not just the technicalities of how do we address this issue with supplements and nutrition changes and like being really smart scientists. It's supporting somebody through hard times, giving them tools to help regulate themselves during stress, reflecting to them. I've done this a few times. It's like whether their relationship or their home environment is serving them, because their environment at home is going to dictate and influence a significant part of their well-being, as it did for you, Sarah. Thank you for sharing. This is just some research that shows how commonly we see SIBO in IBS. So it has quite a large range because the testing is not that great, but it is a decent signal. Love that. So this is just in the middle, you see symptoms. It can cross over a few different conditions. There's also this other guy called SIBO we haven't talked about. We're not really going to talk about that, but just to know that exists, and there's other things that exist, and don't just speak in a very black and white thing. It's just this or it's just that. Usually a few things, or could be another thing. But I just wanted to introduce you to another term and just show you the overlap. Okay, so zoom in for you. What this is in the middle, you see different IBS types. You could maybe think of as also SIBO. Constipation, mixed type, diarrhea type, unspecified type, which is the U. When we go outside the second layer, you see conditions that are also associated, connected, and related. You see pelvic floor issues, constipation, acid reflux, heartburn, nausea, incontinence. When we go a third layer out, we are seeing food intolerances, eating disorders, chronic fatigue syndrome, PMS, erectile or sexual dysfunction. And then when we go the biggest layer out, we see anxiety, depression, and somatization, which is more of a heightened feeling of pain through emotions. For each listed, disorder or symptom here, there has been a documented overlap with IBS. And so when you look at the gut and when you look at SIBO or when you observe IBS-related symptoms, I want you guys to think about the web and the overlap of other different symptoms and experiences that can be connected from that. Is that cool? Is that clear? Okay. All right. For the head nods. Have a think about some questions or comments you have in a second while I close out this part. This is another view of, thank you, Zoe. This is just another view looking at the ideal presentation of a quote unquote typical healthy gut, where more bacterial load will be more distal. What does distal mean? We should hopefully know. What does distal mean? Yes. So quick, fingers are just on the keyboard ready. Far away. Give me 10 points. Good. Further away, we're talking the colon and large intestine. Now, the opposite presentation happens in SIBO, where bacterial load becomes more proximal, close to the midline and the small intestine. I'm not going to get into anaerobes and pH. They're a little bit too nerdy. Now, if you've watched previous masterclasses, you're going to see that this is different because I have agonized over the research and spent hours and hours and hours, and I've gotten help doing this to make sure that I'm accurately communicating to you guys. So this is updated. It used to be 90%, a bit off. 76 to 83% of IBS patients share the same symptom. Which one is it, guys? Take a moment to think about it. Put it in the comments. Oh, you've already answered the question. Okay, Olivia. Which one? This one? Tom, what happened? Are you okay? It's bloating. It's bloating. You look like you're in a bit of pain too. I didn't try to make you like overweight. I asked it to make you look bloated and it did this. So, blame AI. No, it's actually a photo Lockie took actually on the retreat. You enjoyed a lot of great food, didn't you guys? So it's bloating. 76 to 83% of IBS patients share bloating. So it's something you can look out for. If you see your clients feeling like this, those lemon slices were crazy. That's funny, Fez. If they're looking like Matan and Leon, we can look into IBS to being a major likely presentation, therefore potentially SIBO. The prevalence of bloating and distension is substantial, ranging from 16 to 31% in the general population. I think these are healthy cohorts, so don't quote unquote healthy, and as high as 66 to 90% in patients with diagnosed IBS. We think IBS is probably underreported, which is probably where that 16 to 31% is coming from too. So you can look at bloating and distension, and this is not just like I ate a meal and I feel bloated. It has to like clear a specific criteria. If you want to get nerdy, look at the Rome for all criteria, or just think clinically, like consistent bloating. I bloat most of my meals for multiple months. Why your doctor may dismiss your client. You're right. You even got me on the fucking AI. I dropped my hand. I was doing it for the photo. I didn't think the doc was going to come back with a hook, but you always got to stay ready. Now check out the background. What does it say in the background? What's the poster say? You see that? Need attention to detail? Is that the Prime Minister? Probably. But we handled it, Leon. We handled it. All right? Now I don't really look like myself. Put on another 5-10 kilos of mass here. But if you guys ever need help, call us. If you see the piece of paper, we're very upset because he said nothing is wrong. See the notepad in the bottom? We don't think nothing is wrong. We're being gaslit. Nice. Jason Statham Saad. I hope you're enjoying these AI meme photos. Well, they're actually not AI. They're real. I'm going to manifest them. I actually love doctors. I'd be a doctor if it didn't take 17,000 years, but I don't mean to demean them. I'm just making jokes. Doctors might dismiss this because SIBO technically in literature has only been studied for about 20 years. It was called something else like long ago, like something loop syndrome, like 100 years ago, but it was way more clinical and serious and only under strict conditions. So it's relatively new in the terminology we use now. So many doctors and gastroenterologists don't accept SIBO as a valid diagnosis. When we use antibiotics, and I've been on rifaximin, they can be effective. It does improve eradication rates of SIBO. However, there is a high relapse rate if we're just using antibiotics on their own and we're not addressing other factors. And I want to argue for the medical establishment because they have some reason and some good reason to be skeptical, is because when we test for SIBO, it's not that good. The breath tests aren't that good. It's a bit hard to define or to confirm it. And so the gastroenterologists are getting feedback from their major scientific bodies, and they're saying, like, look, it's not that good, the testing. It's not that reliable. Maybe we shouldn't go out and recommend it to a lot of our patients. Oh, I'm sorry that happened, Sarah. Let's pause for a second, open it up. Any questions or comments right now, guys? Let's take a pause. Oh, I guess, Georgia, you have one. Their answer is yes. I'll cover that in a second. Based on what we've looked at so far, what feels confusing? What feels validating? What's coming up for you? What comments, thoughts, questions? Try and engage in this. Yes, Leon.
It might be in the text, but I haven't completely read it. But like, at what severity of someone's like having SIBO would you refer them to get, or like suggest to them to get on antibiotics?
Okay.
Like,
so I would never technically, I know you're not saying this, but I just want to clean up the language. I would never technically suggest a client go on antibiotics or tell a client to go on antibiotics.
Yeah.
What I would say, just let's go language first, is I would educate them and I'd speak. You may want to consider talking to your doctor, gastroenterologist about this if I really want to be safe. And then I would educate them through research and through stuff like this. But to specifically answer your question, at what point would a client maybe look at antibiotics? If lifestyle, stress, nutrition changes and sleep changes, like the foundations, are not really moving the needle, maybe some good supplements that they've put in there, and there's not really moving the needle, then you may look to the next step. You refer to the clinical framework. The next step after the foundations, if they're not working in the first 3 months, the next step would be, okay, perhaps we need to look into phase 2. And phase 2, what is that? In the next masterclass, I'm going to explain to you guys how you can potentially, how the research addresses SIBO and IBS. There's 2 options. No, there's a lot of options. There's 2 main pathways. One that includes antimicrobials, nutraceuticals, which is nutrition-based supplements that have a positive effect on improving a health marker. No supplements, this pathway. Nutraceuticals, lifestyle, behavior change, the whole shebang. No antibiotics. And then there's antibiotics plus nutrition, supplements, antimicrobials, the whole shebang. I did that. When would you consider doing that? When severity is high, when they have gone through those issues for years and years without improvement. I think of, for example, Georgia, for example. Multi-year, severity high, urgency high. I would want to go in and out and be done. When you go in the first time with some practitioners will use antimicrobials, or they use the berberines, caprylic acid, grapeseed extract, no antibiotics, no referral to doctor or gastro. They do that on their own. Not saying you should do that, just saying what they do and what happened to me. You may not get to the bottom of it. You may have needed a heavier hand to address the bacterial overgrowth. If severity is high, Leon, if it's long-standing history, a practitioner may choose to work with a doctor or gastro, do antibiotics alongside of it. I never want to be one of those teachers, practitioners that like try and answer a question but don't actually answer the question, and half of you are thinking, fuck, he talked a lot but he didn't answer the question. So please tell me.
Just wanted to ask another one. With the diagram that you showed us, I don't know if it's that clear here. I just tried to make it myself.
Okay.
With the other disorders, I was thinking, like, if I'm guiding a client through, do we start off with like the outermost layer, like try focusing on, the depression, anxiety, via the somatics first, and then try going deeper, or look at the severity and then be like, oh, we have to focus on the heartburn, on
Mm.
the nausea at the
Uh,
same time while dealing with the somatic, like the other
it, it,
stuff.
it it depends on the severity. I would, alongside that clinical framework presentation we did, so I would have that alongside your coaching. I would use the foundations first, but we need to see, Fez, what their number one or top three symptoms are. Because maybe anxiety and depression is like 3 out of 10, 4 out of 10. Maybe it's 9 out of 10. And so we need to see what is the highest intensity symptom. I would start giving them some relief there while you work on the body systems that are contributing to that or could be a main driver of that.
Thank you.
Great questions, guys. Now, Zoe asked, just real quick context, is this from you, to you, a practitioner, someone else? Just quick context.
This was my gut protocol, and this was based off of my blood work a few years ago though. So this is not a present one.
Yep.
But
do you mind if I ask?
But Charlie.
Cool. So Zoe in the chat has listed 8 to 12 weeks base support, Saccharomyces boulardii, a probiotic, MCT oil that's going to have some antimicrobial effects, quite gentle. Anatosera, I think that's proteolytic enzyme. I need to double check. Ginger, anti-nausea, modified citrus pectin, microbials, berberine, allicin. That's, if I could grade it on like a comprehensiveness of intensity, I would grade that like a 5 out of 10.
Mm-hmm. Okay.
Not bad. Just like, how intense could you go? Like, yeah. There are situations where you would be taking. There are situations where you would take double that. I'm talking about like there's like 4 or 5 extra compounds there. But I think that's generally quite a well justified, decent approach. But it's not fair for me to judge without understanding like the justification, your experience at the time.
Would you say that is the peppermint and oregano oil capsules in the SIBO protocol in Zion, would they be something that acts as more of like a gentle antimicrobial in comparison to something like allicin or berberine?
Peppermint is more gentle. Oregano oil starts to become a little bit more potent and of a potent antimicrobial, sitting alongside the realm of allicin, which, guys, is like a garlic extract, and berberine.
So I was just reading that and I was like, I could have had heaps of garlic. Could have been fine.
As in the raw garlic or the supplement? It's funny
Raw
because
garlic
can be a great compound, except for people who react to it with SIBO. Yeah, Fez, I love her, so, and she gives me, it's a beautiful act of service. Sorry, distract. Any other thoughts or questions or comments on that one?
No, I just wanted to, because you're here, but I also thought it would be helpful for everyone in the group. Just to hear your thoughts on that, because I feel like when I look at that now, I'm like, that doesn't actually look like that intense of an antimicrobials protocol.
Great, your intuition's accurate.
But yeah, when I first did it, I was like, oh my God, this is so crazy.
Yeah, because it's all you know. So guys, that's some context. You might want to, internet connection stable. Maybe copy that down. I used to not copy protocols, but I would take note of what other practitioners are doing and like compare it against literature, compare it against what I would do, what I've done to me. And so take note of that, copy that down. I suspect if you guys look at Charlie's results, he's posting on his story in his school community, I suspect quite a bit of the results are from foundational compounds like that. I do not think he's doing a heavy-handed approach with such people at scale.
Yeah, me too.
Olivia, do you mind asking that one on voice?
Yeah, like I know berberine can be used for helping with PCOS and I believe insulin resistance, like helping with insulin sensitivity. But I've always thought like you have to be careful with that because it's an antimicrobial as well.
Yes.
So it's I don't really know what my question is, but how would you it's like if it's an antimicrobial and you don't know if they've got other issues going on, wouldn't you have to be quite mindful of that
Yes.
too?
That's really cautious, good judgment, Olivia. Really
Thank you.
good, because you're trying to be careful. So dosage will partly dictate the outcome and the potency of that antimicrobial effect. Always remember that, guys. The greater dosage matters. Berberine can be a nice introduction to help improve somebody's metabolic health, insulin, glucose, and keep them around longer, hopefully, in dosages between 500 milligrams to a gram. And when we're talking about using it as antimicrobial, which we'll talk about next time, the dosage can go from up to 3 grams a day. That's what I was on it as well, because it will disrupt, break apart, or help penetrate the outer layer membrane of what's called the biofilm. It's just a film that protects the bacteria from surviving. So you have a lot of berberine, you're poking probably a lot of holes in that, and you can get a bit of an immune reaction. So start low and slow. Monitor symptoms, check in with your client. If it's causing problems, take it out. No, not immune. Some are resistant. It depends on the type. Like Zoe said, I thought biofilms were immune to, I think you mean berberine. It depends on the dysbiosis and the particular bacterial strain. The good thing about a stool test is it will tell you which particular strain is sensitive to which particular antimicrobial. It's very cool. Same with the antibiotics. I like stool tests for that. We're in the weeds. Let's come out of the weeds. Let's get into the soil. We've fought a few doctors who have dismissed us and gaslit us. Hopefully they don't cancel me. Hey guys, how did your client get SIBO? How did your client get these issues? We've covered some of the risk factors. I would just like to highlight some of them again. You can read this in your own time. You can see how stress can disrupt gut motility. You can see how low stomach acid can affect nutrient absorption, B vitamins, B12 in particular, via intrinsic factor, needing enough acidity to help metabolize and break down and absorb B12. Antihistamines, antibiotic history, abdominal surgeries. Watch out for these. If I can tell you, one of the biggest contributors to all gut issues that I've seen in my 11 years. If I could just summarize 11 years of coaching as a health professional, 1,000 clients, look at me. I'm so great. I'm just learning, actually. If I could summarize it all, what would I say? One word. What's the word? It's not one word, that's 6 words. The answer is stress. I've seen people being fixed, healed, helped dramatically from moving environments that were once stressful to environments that are no longer stressful. It could be environmental stress from mycotoxins. It's usually some emotional, physical, mental stress that has contributed to their symptoms. There's nothing more powerful or potent that I've seen than that. Oh, speaking of, this is a figure showing how psychiatric disorders and the symptoms associated with it have an effect on the structure and the function of your gut. There are localized immune changes. There are functional changes in the tissue of the gut. There is even localized damage that can happen to the villi via the HPA axis and all of the hormones that can be contributed or triggered from that long-term stress. Sorry, for physiology of the gut. We're talking about what is the drivers, the underlying explanation of what's going on. Big science nerd overwhelm alert. Let me click on this. All right. Let's try and explain this simply. What do I want to point out? Sensitivity, immune responses. Okay. Let's look at the pluses. You see histamine proteases, things like that. The pluses indicate that they're active. And so when we have food particles, whether they're semi-undigested, whether we have also contributed and they're coming through because you maybe have leaky gut and the tight junction proteins aren't closing that drawbridge down as effectively and it's staying open for too long, you can get C5H, that's also known as serotonin. And When that can happen, we can see a cascade of inflammatory cytokines and mediators, which are represented by the bottom right here, cytokines IL-1, IL-4, IL-6, TNF-alpha. These bottom right, these are just immune cells. These partly trigger the inflammatory process. These can partly trigger skin issues, pain. When we look at mast cells, okay, so that can be remember histamine is inside of these, and these can degranulate and open up, and they can trigger allergy-like symptoms. It's kind of cut off on the bottom, but you can see visceral sensitivity, which is that feeling of pain as well. So we're just showing like a cool image of some of the mechanisms that can cause some of these symptoms. How the brain receives danger or pain signals contributing to visceral hypersensitivity. That's IBS-like pain or sense of urgency to go to the bathroom. Remember one of our students in the last intake had this high sense of urgency to go to the bathroom within minutes in her stressful environment at home. When she went back to her like home, she had none of it. Her symptoms basically improved to 90%. I'm good on this. If we look at this diagram without any text, kind of look how egg can be. Let's make a connection to endometriosis and PCOS/PMOS. There is a relationship between some of the most common female health-related conditions and SIBO or IBS. So we know endometriosis, well, you may not know. It involves the development of endometrial tissue outside the uterus that is driven by and can induce a lot of inflammatory reactions, a lot of pain, infertility or low fertility. Now, when they studied this, when they did observational research, they found that women with endometriosis, which is maybe about 1 in 10, 1 in 7 women, so decently common, have roughly 3 times the odds of IBS compared with controls with no endo. They pooled all these studies together. They weighted them. What does pooled mean? They weighted the studies like not every study is weighted equally. They did that. And across 11 studies and 96,000 women, they found this. Wow. Okay. So now you can think if you see IBS-related symptoms, you should also be screening and looking for endometriosis or PMS-related symptoms. They can be quite strongly linked. IBS in women with endometriosis compared to women without endometriosis was 3.26 with no statistically significant heterogeneity. What that means, heterogeneity means like things are very mixed. Like some people are tall, some people are short, some people are green, some people are yellow. It was consistent. There wasn't much mixed data. That's a good thing. Polyendocrine metabolic ovarian syndrome, this is the new classification, formerly known as PCOS, is another intersection between gut health and female health to watch out for. So we're confident that there's a link between endo and SIBO/IBS. Look out for that, screen for that, talk to your clients, start to think in the multi-layered system as a health professional. Now, Mrs. PMOS, all right, what symptoms do we see? Just a reminder. We'll cover female health soon, but irregular menstrual cycles, excess androgens, you could see excessive facial hair growth, acne across the chin, oily skin, presence of cysts on the ovaries. You're not going to detect that, but scan may. There's a whole bunch of other stuff. Almost all women with what it will be previously in the literature noted as PCOS, many women have been diagnosed with IBS or are suffering from some sort of gut dysfunction. So we could see this multi-layer constellation of PCOS, endo, gut, there is a strong relationship there. So when you see them, assess and observe gut symptoms as well. Don't just look at the gut in an isolated fashion. If there's one big thing you can take away from how you look at functional health after the experience within Trinity is looking at the human body as a multi-system interlinked organism. Psycho, emotional, physiological, all connected. Cool. Any comments or questions on that before we go to types of SIBO? I'm going to ask you, Leon. Leon, do you suspect potentially your woman has PMS-related issues?
Issues. Yes.
High emotionality in luteal phase, a lot of bloating.
Well, she's got a IED, so I think her menstrual cycle is suppressed. I'm pretty sure. I'm
Yeah.
not too knowledgeable on it. But I know when she hasn't been on birth control stuff, her periods were really irregular. Yeah.
That's going to mix things up for sure. My
Mm.
suggestion for you, so you can support her more and she can learn too. She's welcome to watch it. Go in Zion, go in the female health module.
Yeah.
There's a few videos in there by our guest speaker, Olivia, on contraceptives and the pros and cons.
Yeah. Yeah. It's we've definitely talked about like the pros and cons of it, but the more I'm finding out, the more I sort of want to push her towards getting off them. Yeah, for sure. But at the end of the day, it's her choice. So
Yep.
Just got to respect that.
Absolutely. But through better education, you can make a more informed decision.
Yeah, 100%. Yeah, I'll watch it for sure.
There's 3 major types of SIBO. Why we're teaching you this is because the type will partly dictate the response in how you educate your clients on an effective treatment. What I'm not saying is that you're treating them. I have to protect myself, okay? As my exposure grows, so does my risk and liability. So you guys understand what I'm saying. In Zion, we go into this in greater detail. I'm going to introduce you to the 3 main suspected types: hydrogen, methane, hydrogen sulfide. Notice, for example, hydrogen we see is a bit more associated with loose stools, diarrhea. Methane, slow gut motility, constipation, maybe driven by a particular type of bacteria called Smithy. Hydrogen sulfide, more responsive and reactive to sulfur foods, may not respond to a low FODMAP diet. Important to know because it's a major component of people addressing SIBO and IBS. So we think it might determine some of their primary symptoms. Here's a cool diagram from a study. In the little diagram here, look at the hydrogen producing bacteria. So in the 33% of people who did a breath test, 49% had hydrogen producing, 38% had methane producing, 11% had both. It's a mixed bag. It depends. Some risk factors: diabetes, diarrhea, gallbladder removal. The elderly have higher propensity for it because their stomach acidity gets worse. That's a beautiful image. So being aware, there's a few. Where is it? I'll mix the order around. 1 second. All right, let me go here. I'm going to go back. We're going to start with methane. It's a constipation type. Notice clients get constipated a lot. Possibly may want to look into this. How do you know if the Smithy bacteria guy is there? Well, you're probably going to have to do a GI map. You don't need to do a $450 gut test. All right? You guys can order it publicly through iScreen. You can order it privately through Nutripath, through me. Up to you. This is a yuck image. Slower gut motility, you may see, leading to excessive constipation and bloating. Literature consistently links elevated methane production with constipation-predominant IBS. Methane affects contractile activity, peristalsis, those rhythmic contractions that move things along. And this just shows a little bit of the mechanism of how that happens. Now, with somebody who has potentially methane type SIBO and constipation, what else could we look out for? It's a very general question, but what else might come with constipation? That's good. That's good. You both are kind of on the right track. Enterohepatic recirculation. No spaces. No space bar included. Yes. So the recirculation of estrogen, which can potentially contribute to, yes, enlarged and sore breasts in luteal particularly. Cool. Just want to help you guys make some of these connections. Good job. Hydrogen, maybe the most prevalent. We can see a lot of carbohydrate fermentation, so people can be particularly reactive to our high FODMAP foods, unabsorbed sugars and starches in the SI. You might see more loose stools, you might see more diarrhea, a little bit more pain. This is an area of emerging research, so just please don't take it for gospel and concrete. But you can see one presentation having more constipation, another presentation having more diarrhea. You can have mixed types. Just pause on that. And then hydrogen sulfide SIBO. Now, I'll put a little picture of the mitochondria here because it actually can affect the way ATP is generated from the mitochondria. But I won't get into that level of detail. I'm just talking about how it's essential, it's important. Sulfur is a bit complex. But excess hydrogen sulfide can lead to an intolerance, or actually other things can lead to intolerance as well. But they can start to react to onion, garlic, egg, cruciferous vegetables, foul-smelling gas, and brain fog. One thing to remember here is a low-sulfur diet is going to be a temporary change you may make, and a low FODMAP diet they may not respond to. So if you have a client and they decide to go on a low FODMAP diet and it's like, why isn't this really improving my symptoms? Look at sulfur. In your nutrition tracker, guess what a column we have is? Sulfur. Like, it will flag high sulfur foods. It won't be perfect at it, so make sure you double check, but it's there to flag those common issues. So one thing I want you to remember is that if you're someone with IBS and they're doing low FODMAP and they're not responding, you might be confused. You should look at sulfur. I understand. Are you like going to be Oprah? Like, you have a SIBO, you have a SIBO.
I was just finding that image.
It'll be funny because I'll be in jail. Who wants to take over Trinity? A little bit of detail. I'm not going to read it all out. When bacteria migrate proximally and produce hydrogen sulfide where it shouldn't be, the same molecule that fuels colonocytes, so sulfur is actually helpful. We want a degree of sulfur. It's an important amino acid. That helps colonocytes. It helps colon cells to produce beneficial things. Now, too much in the wrong place, generally speaking, can reduce mitochondrial energy production and contribute to intestinal barrier failure, aka leaky gut. So we can see excess sulfur can actually affect energy production. And the symptoms you may want to look out for on the left here, I've mentioned them. And then often it's correlated to some histamine reactions, not responding to low FODMAP. Does anybody think or feel they may have someone they know, a client might be suspected for like some sulfur intolerances, sulfur issues? Put a 1 in the chat. Potentially you, Beck, or someone you know.
Maybe Elizabeth.
Yep.
She has
Yeah.
sulfur burps, not so much the other end, but she gets sulfur burps a lot.
Okay. All right. We're going to get more into this next time, but this is a little bit of how you may approach it. Just wanted to add some little steps in regards to meal timing, stress, reducing sulfur load, some potential compounds, and then some flags. Zoe, you're going to help us test for it. Oh no. But I'm actually going to go back before Zoe shows us that. So we've showed you the 3 types in brief. I just want to explain briefly before we finish off how SIBO causes nutrient deficiencies or can contribute. I have to be careful about the word cause. Beautiful little villi. Yeah. I just need, if enough people want it, and say it only if you want it. Yeah, if enough people want it, I'll do it. It'll just take me a few hours is all. When bacteria in the gut break down, deconjugate bile acids, it can affect bile acid metabolism. And we know bile is really important to help absorb fat-soluble vitamins, yeah? And you see them listed here, A, D, E. If the gallbladder is not sufficiently secreting, if the liver is not sufficiently producing enough bile, then we do raise the risk potentially of nutrient deficiencies. Bile acids are antimicrobial. They are important to help stave off pathogenic bacteria, and they're also important for nutrient absorption. So let's go to the top left here. We see bacterial carbohydrate fermentation. Someone has maybe had some bananas, maybe some artichoke. These are just high FODMAP foods. Maybe some garlic and onion. Oh no, that's not more carbohydrate. They've had some high FODMAP carbs. In the presence of SIBO, we might see hydrogen, methane production, flatulence, abdominal pain, top left. Bacterial bile acid deconjugation, which is that fatty stools because, we're not producing enough bile. We're having just bile salt issues. So you may then get poorly absorbed fat-soluble vitamins, and that may then contribute to vitamin deficiencies. On the right here, we see intestinal inflammation, increased permeability. Actually, let me go backwards. Okay, cool. Let's go to systemic inflammation in the bottom right-hand corner. You guys are familiar with systemic, whole body, inflammation, just it's a very general process. That can be caused by lipopolysaccharide bacterial translocation. What the fuck is that? Speak English, brother. Speak English, Saad. Lipopolysaccharides are a potentially toxic bacteria that can overgrow and be produced in the gut, and they can translocate from the large intestine to the small intestine, and they can contribute to the inflammatory outcomes that we saw earlier on. When we go through this process, then you look on a stool test, and what are you going to see? You're going to see something like calprotectin. Calprotectin is an inflammatory marker that you can detect on a stool test to detect for inflammation. My calprotectin was insanely high. When I got my stool test done, it looked like someone had, the doc said to me, it looks like you have Crohn's disease or ulcerative colitis. That's how high it is. If you can rephrase that question, Sarah, that'd be good. Yes, I had many. That's called translocation. If you go in, and Zoe asked about LPS, we'll probably cover it more, but go in Zion. If you type in LPS or lipopolysaccharides, there should be a good explanation there as well.
Can you just re-explain what you just said, like what the difference is with this one again, please?
With which one?
So like what you just explained, like what LPS bacterial translocation is. Like if it's not that one that I just said where the bacteria travels up from large to small intestine, what is that again? Can you just reiterate that, please?
Best.
Just short, just like paraphrase, like because I thought that's what you said, but
Let me just pause for a sec. You thought I said what? Just so I understand what you understand.
Yeah, I thought when you were explaining the bacterial translocation, I thought that was when the bacteria travels from the large intestine to the small.
Yes.
Is that what you said?
Yes.
Oh, okay, yeah, cool.
And a lipopolysaccharide is an endotoxin. Bad guy that secretes inflammatory things to damage the host, aka you. So it when you have, let me make my screen bigger. When you have what's called a negative gram bacteria, like E. coli or Klebsiella, something that can damage you, on the outer part of that makeup, part of it, what it's made up from is LPS, lipopolysaccharides, and they're like this toxic anchor that can secrete damaging compounds to the host. It's a potent immune trigger. When you go in with antimicrobials, antibiotics, we break these biofilm agents, you'll see later, we break these apart. When they break apart, their contents inside come out and they can trigger immune reactions, also known as potentially a Herxheimer reaction. You don't want that smoke. This is me, sad on the toilet. Now, this is a real photo. I've just changed my expression. How SIBO can make you poop your pants. This is a mechanism of how stress can make someone more susceptible to faster gut motility, more pain, more urgency. Very common. Visceral hypersensitivity is this threshold for pain. It can be lower, particularly when you're experiencing emotional distress. And then this guy called secretory IgA, this protective immune guy that sits as a protective part of the mucosal layer on the gut. It's the first line defense, one of the first line defenses in your gut. It lines your intestines. People with autoimmune conditions typically have lower secretory IgA. People with more inflammation, people with underlying gut issues, people who are stressed more have lower secretory IgA. And this is plausible to explain why some people may be more reactive to food poisoning than others. How do we improve this? Well, we should know that HPA dysfunction, stress is a major driver of this lowering. We should also know sleep deprivation. So before you put in like compounds to improve the immune system and the gut system, please address those things first. Like I can tell you like Saccharomyces boulardii, colostrum, other probiotic strains, they can improve this and they can make you shit your pants less. Great. But please make sure you address the underlying lifestyle stress, sleep triggers that are making it harder for them. Any questions or comments?
I have a question on stress. And I know we've covered this a lot, but so obviously environment is an extremely powerful factor in someone's gut health. If they are so e.g. in a job that they're not happy in, but they're only there for another 8 weeks, or they're living with family, but it's only temporary, it's only for another 6 weeks or that sort of a thing. I'll often give my clients or recommend sort of nervous system practices, things they can do to ground themselves and get through the time. But is there anything that you would recommend if someone has a definitive end date, like, yeah, I am moving out in 6 weeks, or yeah, I am leaving this job in 2 months? Is there anything additional that you would do in that time or tell them in that time to allow their bodies to begin to relax again if they are a bit more sensitive to gut changes with environmental stress?
Relax again. Would there be anything I would do to help them relax again? So this is more of a nervous system stress question.
More of like they do the breath work, they usually will have passion flower, L-theanine, things like that. They're doing all the right things. They're just still in a situation that is quite stressful, but it's not forever. Ways you would coach them, or things you would say, or if there's anything additional you would encourage for symptom management that you might be a little left of center. That's
The symptom management. Okay. So in conjunction with the stress nervous system things you're doing, is there anything you would do in the meantime before they move out for symptom management? Is that right?
based off of, like anxiety/stress in a either family environment or a work environment.
Are you looking for a lifestyle answer or like a supplement nutrition answer?
I feel like supplement nutrition is just where my brain tends to go first, but I would love to know your perspective. If again, they're already doing the 10 minutes of morning sunlight, they're already sort of doing the nighttime routine. Some of my clients will also dabble in like ashwagandha and
Is there a particular symptom that you're trying to improve here?
So a few of my clients that I'm thinking of, there's probably like 3 off the top of my head that come to mind straight away. Their gut issues are a lot more prevalent at particular times where home life is a bit more stressful or work life is a bit more stressful. And if it's only a temporary thing that's quite quickly resolved with environment, but we know that environment will be changing, it's just not changing right now. Instead of saying, well, we're doing all we can between now and then, is there a way you would speak to them, or is there an additional supplement or something you would say, hey, this is a short period of time, this could be helpful? E.g., I'm sure if my clients went to the doctor, they'd be like, sweet, let's get on some anti-anxiety medication till you're out of the situation. That's not what I would give my clients.
Crazy you said that, Sarah. It's what I just thought about. And I'd never smoked weed in my life. Because it's temporary, I wouldn't necessarily have them running to the shops to get another $100 of supplements. Lifestyle, minimize, remove trigger. They're doing the nervous system stuff, great. I know what it's like to grow up in a very triggering environment, and I know some of you might have some answers for Zoe. Please share them in the chat. What I've found for me and my clients to be particularly helpful is we need to manipulate the senses. This is first, well, this is one of them. We manipulate the sound sense and the visual system. And so if you could help them create a cocoon of safety with their environment. I walked around my house back in the day when I lived with my family, I had headphones on a lot. I was just plugging in and plugging out. Okay, so I would get them sound, help them create a really safe cocoon environment that they can retreat to. I would also improve their visual system and what I could just practically do to just minimize exposure to the stress stimuli as much as possible. And protecting auditory triggers can be particularly helpful, I've noticed. So I would plug them into headphones and getting them to listen to uplifting, calming, regulating things on tap. And I actually don't mind Sarah's suggestion at all. If they have a healthy relationship with marijuana, we do know it has anti-anxiety calming effects in people. Like if they have schizophrenia background, I wouldn't touch it. But that's uncommon.
About to say, I feel like I've got some family members who should not be smoking weed, who smoke weed, where it becomes such a trigger for me.
And you can do some CBD oil.
Yeah.
You can do high dose theanine and glycine. I'm talking, not medical advice. I'm talking potentially, 500 milligrams to a gram.
I think in the anxiety stack that Kiara and Danielle had shared with us, that was like 800 milligrams of theanine.
Yep.
Yeah.
And Georgia makes a really great point. It's contextual. Obviously, we're not like doing a
Mhm.
full case study here, but it's very contextual to like the state of their nervous system, hyper or hyper.
Mhm.
But I would first start with controlling the triggers or manipulating the senses to minimize the triggers.
Cool. Thank you so much. This is, yeah, big thing with a lot of my clients.
Yeah.
Like they know they're smart enough to take action to change their environment, but sometimes there's a window of time where it's like, shit, I'm still here for 6 months.
Yeah.
So,
Yeah.
so
True.
yeah, thank you for that. It's really helpful. Thanks,
And
everybody.
and just generally like helping them look at their situation as more empowering and helping belief shift them towards seeing their adversity in some type of positive light,
Thank you.
changing their relationship to it. Yes, I have looked into kava. I've tried kava before. The closest I've got to drinking alcohol. Don't know a ton about it. Testing. How do we actually have confidence whether this is actually happening? Zoe will show us here. So this is a diagram showing the frequency of SIBO using a glucose and lactulose hydrogen breath test with people with IBS. On the right here, in the dark green, you can see healthy subjects who are not classified to have IBS. 1% of them seem to have SIBO in aspirate culture. So they did I think they got the bacteria or took something from their gut and analyzed it. There was a glucose test in the second column, and then there's a lactulose test, which is the least reliable in the third column. And we see people with IBS quite commonly seem to be diagnosed with SIBO as well. Keep in mind the limitations of that. This just further supports what we were saying earlier. Now, there are 4 main ways you can screen for SIBO. One is a breath test, one is a GI map, third is blood work, and the fourth I'll show you in the next slide. Sorry, let me go back to answer. Not necessarily, Sarah. So Sarah's like, is the lactulose test the most effective? Because it detected the most SIBO. Actually, the lactulose is the least effective. The least sensitive and reliable. It can have false positives. Anytime you have a test, you can have what's called a false positive. Let's say you go in for a cancer screening, breast cancer screening. There is a percentage of people who go in for a breast cancer screening and they get a false positive. They're told they have breast cancer and they don't actually have breast cancer. So my recommendation, generally speaking, would be if you guys are going to get a test and scan and someone tells you, we think you have this, go for a second opinion, because false positives and false negatives exist. And that can change your life to get a false diagnosis. In this case, the glucose test is more reliable and sensitive based off research. This just describes how it works. Not going to read out every word. You can read it in your own time. In one sense, we're looking at bacterial fermentation and the gases produced with the breath test. In the GI map, we're looking at the large intestine, but the stool quality from mostly the large intestine. It's harder to see small intestine stuff there. We're looking at inflammatory markers. We're looking at bacteria. We're looking at potential risk for colon cancer or risk factors for it. In blood work, people seem to speak about blood work with gut with quite a bit of certainty. And I think this is misguided and can be quite dangerous because blood markers and gut do not have strong research behind them. Looking at someone's blood work and saying, you have this is quite arrogant and doesn't have a lot of scientific confidence behind it. What you can see is patterns of inflammation, poor digestion, nutrient absorption issues. You could see eosinophils, white blood cells, potentially linking to parasites or other gut-related conditions. But what I don't want you guys to do is look at a bunch of bloods and then tell your client you probably have this when the weight of the evidence behind blood work and gut issues is low. I am happy to be proven otherwise. I would like to know better information. So as we learn more, we will learn more. But blood and gut connect is moderate to low. I would love it to be more, but my emotions are irrelevant here. What you can do is stack these testing parameters together with symptoms. And when you do that, you have a higher degree of certainty. It's like, let's say you're trying to see if someone's being unfaithful in a relationship. Well, just a feeling is low certainty. It just feels off. Well, emotions are quite unreliable. Let's look at their Instagram. Who are they following? Who are they DMing? Are they secretive? Do you sometimes watch them on the Find My and they're at weird locations? Or there's inconsistencies in what they're saying. You build a case. And we do the same in building a case with testing, with gut, whatever health issue. So don't put too much stock in one particular test. Build a case. Really, G. Please share.
Yeah, I don't really remember it too much as a kid, but I just remember that I had gone to the hospital twice, and both times they sent me home with gastro. And then my mum had to push and take me back and said, like, this is not gastro, like this is ridiculous. So she had to really like kind of advocate because they just sent me home with gastro twice. So it took about 3 goes to actually get it was originally ulcerative colitis and now it's Crohn's, but it took a long time to get a diagnosis.
Thank you for sharing that, because that gives everybody here perspective on the challenges and limitations. In my experience, actually, let's go breath tests. The lactulose breath test is very low sensitivity. The glucose one is better performance. But it was helpful for me. This is mine. On the left, I don't need to break it down. Like, if you want to read it in detail later, you can. On the left is my before test. On the right is my after test. And it corresponded with a large symptom improvement. So I have a high degree of certainty in the test for me, but that doesn't mean it's going to be the same for you or your client. But it did work for me quite well. In regards to symptoms, finishing off here, this might be the second last slide. I've built for you guys a symptom map to build a bit of clinical confidence. Now, this is a combination from research and from my clinical experience. That's what the weighting is considering. So let's say bloating here, that worsens throughout the day. What it suggests, fermentation in small intestine. What is the confidence weight that someone may have SIBO? Based off that symptom, I have a high confidence weight. However, in the later column, other causes to consider. Functional dyspepsia, so it's a version of like acid reflux. Maybe lactose or fructose malabsorption. Bloating around the belly button specifically. You won't find strong research with that level of specificity, but anecdotally, me and my colleagues find a strong correlation. And I mentioned that, not validated for SIBO, but X and Y. Egg sulfur flatulence, high, and it just keeps going. So constipation dominant, diarrhea, moderate to high. What is, to point symptoms worse with fiber, prebiotics, probiotics, FODMAPs? However, you can have a FODMAP sensitive IBS without an overgrowth of bacteria. Okay. Now, what I see to be low certainty from research and my experience is like fatigue, brain fog, low mood, histamine reactions. Why I have a low weighting to that is because it's very general and it can be correlated to a wide variety of other conditions. So it would be a little bit irresponsible and not a good scientist of me to put that high, given the complexity and the other concurrent conditions that can coexist with it. History of food poisoning, we've seen that as a major risk factor. B12 deficiency has a stronger link than iron deficiency. So before I answer your question, Sarah, 1 second. When you guys start to work with a client, this is all you'll have, most likely. You'll most likely just have symptoms to build confidence from. So I would recommend you refer to this to build your picture of what you suspect may be happening. To develop more confidence, you may combine that with these testing. But a breath test is like $200. A GI map is $450. A blood test, like if you go through iScreen and get my full suite, is $650 or $100 at the GP. We have to be mindful of the client's budget. People take for granted the client's budget. They request $1,000 of supplements and tests, and now the client can't even work with you anymore because they've miscalculated the cost of getting a coach. It's very easy to say, hey, go get this test without consideration of like someone's budget. What do you do about all this? In the next masterclass, we will cover it. What else causes FODMAP sensitivity? Zoe wrote FODMAPs. Did that answer your question, Sarah? No, it didn't. Stomach acid, so bile insufficiency or dysfunction, because bile is a potent antimicrobial, and enzymatic production issues produced via the pancreas, the mouth, and the small intestine. If the body struggling to produce enough, then we can have issues there. And there's also a little bit of an overlap between potentially histamine sensitivity, because histamine-rich foods can cause symptoms that look like FODMAP sensitivity symptoms. Okay?
Can you please say that one more time?
Histamine-rich foods can cause symptoms that look like high FODMAP symptoms, like sauerkraut, like fermented foods, even bone broth, higher histamine, but also fermentable, sauerkraut stuff, could be histamine. Histamine's a big bag of worms. That's funny, big bag of worms. So to test for that, you may put in an antihistamine to see if it helps, or also try a low histamine diet, just to test. I'm sorry, I wish the body was more simple, but it's endlessly complex and fascinating. If it's too complex for you, this is a bit awkward. There's no escaping now. No escaping, Paul. Can you get the Bali Belly protocol? Yes, you can. If you type in Zion, Bali, let me fix that for you, please. Live observations.
A lot of people that I know who or know through people, mutuals, who have Crohn's, which, just to confirm, Georgie, do you have Crohn's or ulcerative colitis?
No, mine's Crohn's.
Crohn's, okay. So from what I know, you may actually be the opposite of my observation. But one thing the people that I've spoken to who have had Crohn's or friends of friends, they tend to be more inclined to have things like, and this again could be more of an observation, but I want to hear thoughts. Just really random foods that are not like, aren't good for you, in quotation marks. E.g., first thing that comes to mind is like one of my old clients who has Crohn's. She just loved like sugar-free bees on an empty stomach. And then one of my friends' clients who had Crohn's would have like, he liked the Muscle Nation casein custard, so he'd have 12 servings at a time. But one string that I've noticed of a common habit is like sporadic nutritional inclinations.
Craving?
Like a craving, but acted on, and the food tends to have very little nutritional value, and like very drawn to hyper sweet sort of foods that don't have a lot of nutritional value, but eating foods that tend to have nutritional value but be a little bit more boring, they will tend to skip or avoid. That's my observation. Okay,
so from my understanding of what you're saying, Zoe's explaining a situation where why do some people have certain cravings towards foods and others don't, particularly in those with health conditions. Like, why is that person craving like hyperpalatable foods and sweets or seemingly random foods? A few reasons potentially, but outside of just normal reward systems and behavior, we know there seems to be emerging evidence that the microbiome and certain bacteria can influence cravings. Okay, cool. Certain bacteria can influence cravings, it seems. One example of that very simply is Candida. Candida is a yeast overgrowth. It thrives on sugars and carbohydrates. And so it can kind of, this is a bit of a strong word, but hijack the limbic system in a way, or manipulate the limbic system and craving control. I think via the vagus nerve, it talks to, I think it's this microbiome talks via vagus nerve to the brain and can ask the host for trigger the host to crave certain sweets and sugars. And there's also research I believe I've seen on overweight to obese populations that seem to crave more hyperpalatable foods, partly due to microbiome changes, dysbiotic, commensal, imbalanced flora that can predispose an obese to overweight person to crave more sweet, sugary, and hyperpalatable foods. Because overweight to obese people have low microbial diversity on average, and typically more gastrointestinal issues, worse microbiome, which can then trigger more cravings. So those are two things that I've seen. Hopefully that partly answers that.
Yeah, that was along the lines of what I was thinking. But yeah, so thank you. I just wanted to share to see, because you've obviously dealt with a lot of people in regards to that as well. So you've had a bigger
Sample.
Yes, thank you. Sorry, didn't get enough sleep last night. Haven't had my creatine.
Go ahead, G. How's that sound? Sounds fun? Yes, I know you'd love it, Matan. All right, do you want to say hello? Say hi?
Hi guys. Now everyone's smiling. I just
All the best. Peace and love.